My name is Dr. Chris Carter. I'm the psychologist. I work at Spaulding Rehabilitation Hospital. I'm the director of continuity for brain injury and spinal cord services for the network. I've been working in the area
Dr. Carter?
Yes. As I was going to say, I've been working in the area of brain injury for almost 30 years, both inpatient and outpatient, and certainly see the impact that substance use has, both in terms of creating the brain injuries as well as undermining the success of individuals who've recovered from the initial injury and now are trying to make their ways forward and have to also deal with pre-existing substance use issues. So I'm glad to have an opportunity to speak with you today. So why are we talking about substance abuse disorder and traumatic brain injury, acquired brain injury together? That's because there is a multi-causal relationship that a history of acquired brain injury increases the risk for relapse or a new substance use disorder. The substance use disorder itself can undermine the goals of neurorehabilitation and recovering life's previous trajectory. And neurological injuries can be a barrier to the substance abuse treatment. By the end of today's training, I'm hoping that you will be able to answer the following questions. How might the consequences of an ABI pose a risk for relapse for an individual with a substance use disorder? How might the consequences of an ABI interfere with an individual's ability to benefit from traditional substance use programs? And what adaptations or accommodations can help individuals with both an ABI and a substance use disorder be successful? Acquired brain injury can be a barrier to substance use disorder treatment for a number of reasons. Newly injured individuals, particularly those between the ages of 25 and 65, may lack insurance coverage for substance use treatment. They may not be able to drive, use, or have access to public transportation, or have a friend or family member who can provide transportation to treatment. Many have mobility challenges and are unable to negotiate stairs or walk independently. Many clinic settings have limited access, which includes ramps, elevators, accessible bathrooms, wide enough doorways, etc. The cognitive load of traditional programs can be more than the individual with an ABI can manage. This can include amount of attention required, ability to take in information independently, retain and apply information, to tolerate ambient levels of sensory stimulation. They have sufficient cognitive stamina to tolerate a full program. They may require supervision in unfamiliar environments, assistance with personal needs, with skill acquisition and application. Traditionally, services have been siloed or bucketed, such that the existence of one treatment need may preclude access to or participation in what should be complementary services, or require the coordination of services from multiple providers. Individuals with an acquired brain injury may have problems with the regulation of thoughts, feelings, and behavior. They may have difficulty benefiting from experience and remembering information from one session to the next. There can often be a disconnect between intention and behavior, where an individual has an intention to use the skills that are being taught, but when it actually comes time to apply them, they fall short. Individuals with an acquired brain injury may not fit in well with others in the environment because of problems perceiving, understanding, and behaving according to social norms. There may be differences in communication or learning style that make participation in didactic training and group interventions more difficult and frustrating for the individual, so that the individuals may become frustrated, feel disconnected from the program, feel socially isolated, and leave treatment prematurely. Now, these are the areas of cognitive functioning that we see most commonly impacted by brain injury. You've been learning about these in previous presentations. Specific profiles obviously will vary depending on the nature, location, and extent of the injury. We have different forms of attention, being able to select and identify what is important to pay attention to. We can think of attention as having a span or an amount of information that an individual can manage at a given time. We can think about attention as the ability to be able to sustain attention and focus, particularly in the face of competing stimuli. And another feature of attention is the ability to shift from one area of focus to another. The skill of categorization is really starting to get at abstract thinking, the ability to apply information or lessons learned in one setting to similar or common areas of real life. Problems with memory can include difficulties in being able to access previously learned information. It can include problems with acquiring new information. And it can include the difficulty of remembering that you know what you know when you need to know it, the idea of perspective memory. Our clients can often have problems both with taking in information and language comprehension, as well as generating language. They may have reduced processing speed, that is, they need more time to take in information, and they may have trouble keeping up with normally paced learning activities. They may have difficulties with executive functioning. Those are the abilities that allow an individual to identify that there's a problem, to be able to think about alternative solutions to that problem, to be able to plan and carry out those solutions, to be able to monitor the effectiveness of the solution, to drop that solution and try something else if the initial situation or the initial solution isn't working very well. And these are the skills that are really critical for an individual to be able to function independently in the larger society. Metacognition refers to the ability to think about thinking. It really is a conceptual process that allows people to function in a more abstract capacity and move beyond just straightforward concrete thinking. Difficulties with executive functioning are probably the most common because of the sensitivity to injury of the neurological structures involved and the complexity of the underlying functions. Individuals with executive functioning deficits often exhibit impulsivity, disinhibition, hyperverbosity, poor problem solving and decision making, and poor control of emotions. Cognitive rehabilitation approaches include teaching individuals to use formal problem-solving strategies, which may include approaching a situation in a systematic manner, identifying and analyzing problems, considering alternative solutions, including possible outcomes, prioritizing solutions, carrying out those solutions and monitoring their performance and altering the solution as needed. Following an acquired brain injury, there may be behavioral and emotional changes which can interfere with participating in traditional programs. They can be very disruptive. The individuals may become easily frustrated. They may have problems with irritability and agitation. They may have difficulties with impulsivity and acting before thinking. There may be an increase in refusals or resistance to attend therapy, to take a shower, to participate in group activities. These individuals may become more verbally aggressive, yelling and swearing when they're frustrated and upset. There may be, in fact, problems with physical aggression. Individuals following with an acquired brain injury may be at greater risk for trying to leave structured environments, have a higher risk for elopement. And there may be a loss of social skills, which makes it difficult for them to connect with new people, to form new relationships and friendships. Some further examples of problematic behaviors that can take place can be an element of disinhibition, where the individuals are losing their filter and they're thinking and they're saying what they're thinking, which may be inappropriate use of language and may be inappropriate content. There may be a denial that anything is wrong or different. The challenge here is distinguishing between an inability to see that there is a problem, a lack of awareness, versus a psychological unwillingness to consider or admit that they have a problem. When they get frustrated and there's physical aggression taking place or poor impulsivity, impulse control, there may be elements of property destruction taking place. They may throw furniture or punch holes in the walls. They may find themselves crying or laughing at the wrong time. Affectively, they may be more easily triggered, and they may have a more difficult time regulating that affect once it's gotten triggered. There may be problems with initiation. Often it can be a challenge to distinguish between individuals who are depressed, so that emotionally they're lacking that initiation and drive, versus more neurologically lacking the energy or the ability to initiate activity independently. They're not really resistant, but they need the outside world, the environment around them, to prompt and cue them to engage in behavior. And they may have difficulties with making bad or questionable decisions, again, because of those executive functioning deficits, the inability to appreciate the implications of the decisions that they may be making or the actions that they may be taking, as well as having a difficult time being able to connect the dots and seeing the patterns in their behaviors so that they can have an appreciation that what they're doing, these solutions are not working. An important component to this work is obviously identifying the presence of a traumatic or an acquired brain injury. You've seen other examples, and I'm just going to highlight a couple of the tools that are available. We're trying to get a sense of the extent to which the individual has the cognitive skills that they're going to need in order to be able to participate in the substance use treatment program. Do they have adequate concentration and attention? Do they have enough processing speed that they can keep up with the group and with the activities that are being presented? Do they have the ability to form and retrieve new memories? Can they remember what you talked about during the last session? Can they remember what took place between sessions? Can they remember the effects of the homework that may have been assigned to them? Do they have the ability to initiate tasks independently, or do they need others to remind them? Do they need to be in an environment that prompts them to engage in identified tasks instead of being able to do that on their own? Do they have enough impulse control? Are they going to be so disinhibited or so impulsive that they're going to be disruptive to the rest of the treatment program? Do they have the ability to plan and organize for the course of their day to be able to take what they've been learning and apply it to their day-to-day activities? Do they have adequate mental flexibility? Can they shift from one activity to the next independently? Can they let go of historic patterns of behavior in order to try new things? Do they have sufficient self-awareness and ability to make good decisions? All of these are subject to disruption following a brain injury. So assessment needs to determine where an individual fits on this continuum in deciding treatment modalities, goals of treatment, and needed accommodations. Are there the needs and the demands, the limitations of the acquired brain injury the more central piece, in which case the intervention and treatment may need to focus more primarily on that acquired brain injury? Or are the needs and the disruption from the substance use of greater prominence and a greater theme, so that it's interfering with the individual's ability to move forward with their acquired brain injury? In the earlier stages of recovery from brain injury, we'll often identify that the individual is not ready for substance use treatment because they don't have a sufficient level of cognitive skill to be able to tolerate, participate in, or benefit from a formal substance use program. These individuals typically are not ready to be in the community on their own, which typically means they aren't ready to be responsible for their own sobriety. Instead, we talk with families about maintaining a substance-free environment, limiting contact with individuals who might undermine their sobriety, involving family in Al-Anon and other support activities, perhaps beginning contact with an individual clinician to maintain motivation and monitor recovery to determine when the individual is ready for more formal focus on this substance use disorder. As the individual recovers sufficiently that they're able to work on being independent in the larger community, we typically then recommend that more formal substance use treatment be part of that work, as the individual will need to be able to be responsible for their own sobriety, if they're to be truly independent in the community. There are a variety of screening tools available that can help to screen for acquired brain injury. I want to emphasize that these are to be used for the purposes of only for screening for the ABI, not diagnosing. Positive results should trigger more formal assessment by specialists experienced in diagnosing acquired brain injury. I'm going to talk about the ACE, the HELPS, and the OSU tools, which are brief and easily administered and scored. And I can see from the introduction that you've probably already been introduced to these, so I'm just going to touch on these briefly. With all three, it may be beneficial to involve family members or caregivers who may be able to provide more reliable or complete information, keeping in mind that individuals may not be the most accurate historians. They may not be aware of previous instances of brain injury. The ACE is the most useful in looking at more recent injuries. The most useful areas in the injury characteristic for your purposes will be the responses to the questions about amnesia for events before and after the injury, as the longer the duration of the amnestic period, the more severe the injury. The symptom checklist can be more useful, particularly if these symptoms are still present at the time of screening, as these will begin to point to potential problem barriers and need for accommodation. Again, the HELPS is a brief screening tool that can be helpful in flagging for ABI history and potential barriers to treatment and need for accommodations, particularly if the listed problems remain present at the time of screening. While there are no specific cutoff scores, the more items that are endorsed, the more likely that the ABI is going to be a factor impacting participation and response to treatment. The OSU is another brief screen that can help to identify that a brain injury has occurred. Positive responses should trigger further investigation into what sort of treatment the individual may have had, previous or current cognitive changes or difficulties. More formal assessment of the ABI and its impact may be warranted. With all three of these screens, the intention is to identify the potential presence of an ABI not for the purpose of screening such individuals out of treatment, but to begin the conversation as to what adaptations to the program may be needed for this individual to be successful. I'm going to pause for just a second. We didn't talk about this at the beginning, but I've allowed time at the end for questions. If you want to enter those into the chat room, Justine will keep track of those and will help me at the end. I've also planned for an interactive activity that will best be done through the chat feature. So please feel free to ask questions and we'll address them at the end of the presentation. So if you've identified that an individual has an acquired brain injury, the next step is to really determine and understand the impact for this individual on their cognition and their functioning and the areas that we've been talking about that are going to be necessary to be successful in the program. A neuropsychological assessment is recommended for anyone who's had a brain injury and continues to experience cognitive and/or functional changes. As neuropsychologists are not universally available or may not be able to see the client in a timely manner, if the individual is in a cognitive rehabilitation program, their speech-language pathologist or occupational therapist may be able to provide recommendations for accommodations. In brain injury rehabilitation, we seek to remove barriers to participation in life through either restoring lost abilities or adapting the environment to support greater autonomy and participation. So where the individual is not able to recover lost abilities, can the environment be adapted to allow the individual to participate successfully in life activities? Substance use treatment being one of those areas. So what kinds of accommodations can be made for individuals with an acquired brain injury? I think the first thing is to sit down and have a conversation with the individual to determine their level of self-awareness. What do they observe or know about themselves in terms of their communication and learning style? Get a sense of how well they read and write or observe through samples. Find out whether the individual is able to comprehend both written and spoken language. Things to consider are speed and accuracy, level of effort required, sustainability of performance, level of complexity of both the material and the environment in which it is being presented. Can they do better with larger print, with less information on a page, have more time for processing the information? Do they need repeated exposure? They need to see the material several times before they're able to really take it in and work with it. Is there a difference for them between one-to-one communication versus being able to follow a group conversation? They may need to have someone sitting with them or working with them or reviewing with them the content of the material from groups. We had a substance use counselor in one of our brain injury programs a number of years ago who would bring some of the clients to AA meetings, and they would sit in the back in the corner, and they would then debrief afterwards. She would encourage them to just try to take in as much as you can, and then she would have a smaller group with the individuals where they could review and cover some of the highlights of the meeting to get as much as they could out of that experience. Is the individual's performance consistent across the day? It's very common to see individuals be able to perform well in the morning, but as the day goes on, their performance tapers. Can changes be made in the individual's therapy activities to address that or to be in sync with that? They may do better with individual sessions in the afternoon and have more of the group activities in the morning where they have more cognitive capacity for that. They may need more breaks during the course of the day in order to recharge and recoup. Are they able to sustain their performance for the duration of the activity, or do they need more frequent breaks? Try to ask about and observe a person's attention span. Be attuned to whether attention seems to change in busy versus quiet environments. Ask about and observe a person's ability to learn new ideas, information, and routine. Inquire as to strengths and weaknesses or seek consultation to determine optimum approaches. This is where caregivers and family members can be of particular value as they've been living with and observing the client under close quarters for quite a while, and very often will be aware of things or see things that the client may not be aware of, may not be seeing for themselves. Again, fatigue, endurance, and sustained performance need to be considered in planning out the individual's activities for the day. Consider, too, that some people are more visual versus auditory learners, so they may need more visual material or photographs, pictures, video, rather than sitting and listening to somebody speak for a long period of time. Some people may need more repetition and rehearsal. They may need to try things for themselves. They learn by doing more than by listening. Consider how much information they are expected to acquire in a given setting. I've seen some programs have a very simplified version, and they try to limit the depth of the material that they provide in order to allow individuals to have greater mastery. Traditional goals and areas of treatment for substance use disorder involve craving management, social skills training, time management, developing alternative leisure activities and reinforcers, identifying and resisting triggers, treating comorbid mood and psychiatric disorders. This is obviously true for individuals who don't have an acquired brain injury, but become even more pronounced and more important for individuals with acquired brain injuries, because the underlying neurological mechanisms may have been damaged. And so individuals may need more support and more focused training in these areas. While these are common components of substance use treatment, they are also interventions that are frequently recommended for individuals living with an acquired brain injury. Problems can arise in translating learned skills to home and community, as well as follow through on practice and homework. Once again, families can be very helpful in providing reminders or prompts to use these acquired skills in real-world settings. In our rehabilitation center, we bring families in during the course of treatment so that we can teach them the kinds of prompting and support that our therapists are providing so that they can translate this information, these skills and abilities into the home setting so that the individual can continue to engage in the trained behaviors. Factors that promote recovery from a substance use disorder are very similar to what we find is needed for successful recovery from acquired brain injury. The more individualized the treatment plans are. One size does not fit all, particularly with brain injury. Every brain injury is a little bit different. How the individual is affected by the brain injury is a little bit different. Consider that the individual who had the brain injury is a unique individual as well. And so you may need to tailor approaches and treatments to individuals a little more with an acquired brain injury than you would for your general clients. Family and community support are really critical. Again, one of the deficits, one of the difficulties we see that our clients have is that skills and abilities learned in one setting do not necessarily translate into other settings. So the more that training can take place in the environment in which it's going to be needed, the more successful the individual is going to have. And again, this is where families are going to be particularly useful. If the individual is involved in rehabilitation programs, networking with the client, with the therapist there to see ways in which there can be some cross-fertilization or cross-training done so that the individual has a broader exposure to settings in which to practice these new skills. Successful treatment usually involves a network of care providers, as you've been hearing. Individuals with brain injury are usually served by a variety of providers. There may be a neurologist, a psychologist, a psychiatrist, a physiatrist, social workers, occupational therapy, speech therapists, case managers, all needed to help people over the course of their recovery. Similar to substance use disorder, acquired brain injury is often a chronic condition for individuals where we can expect that further injury is going to be at risk, or their recovery is not always going to be in a straight line. The more aggressive the treatment and the sooner people are engaged in treatment for acquired brain injury, the better. Usually the greatest amount of gain takes place within the first 6 months to a year. Within that, of course, that's not to say that beyond that time people won't benefit, but we see that the greatest amount of recovery takes place in the early window. So the more that individuals can get access to therapies, the better they're going to be able to be. One of the same features that afflicts individuals with substance use disorder is a common problem for people with acquired brain injury, and that's social isolation. So finding opportunities for affiliation, for meeting other individuals who have similar issues, who are in the process of recovering from their brain injury, can also be useful, just as it is for substance abuse survivors. We recommend some of the same treatment approaches for individuals with an acquired brain injury, although they may need to be altered a bit. We still like to see the use of non-confrontational motivational interviewing approach, in the sense that you're trying to help the individual gain insight through more of a Socratic method of asking them to consider or think about the patterns of that have been taking place that are in need of change. As you've been going through and collecting information to follow up with the individual, one of the first goals of treatment in an acquired brain injury is making sure that the individual has a reasonable insight and awareness of their problem so they can really engage and participate and embrace the treatment that they're getting. The development or the arrival of an acquired brain injury as a result of substance use issues can actually provide an opportunity to have conversations about treatment that the individual may have been resistant to prior to the injury. Discussing the health concerns and recommendations related to their brain injury in terms of ways in which they can avoid having further injury. Obviously, being able to maintain sobriety and stay away from recreational drugs is going to be high on that list. Having a discussion about their sense of the potential benefits of the use of their drug of choice, and further conversations about how that might interfere with or impact the areas that they're working on in their brain injury recovery. So individuals who are already having problems with coordination, balance with walking, considering the impact of alcohol or marijuana on their risk factors. Talking about with individuals who may now have a seizure disorder as a result of their brain injury, the potential risks that alcohol use poses for individuals with such disorders, the ways in which the recreational drugs that are frequently used may increase the risk for further neurological events such as stroke, or the ways in which the drugs may interfere with the medications that individuals are taking in order to enhance their recovery. The presence of an acquired brain injury, particularly if it is a result of their substance use disorder, can be an opportunity to shift the conversation about their substance use. So you may be telling me that you're not sure you really have a substance use problem. But what would you say if your accident, do you think that your accident would have happened if you hadn't been drinking? What would you think about someone who continued to use a substance use after being told that continued use is likely to be life-threatening or will prevent them from reaching their goals in life? Would you consider that that individual might have a problem with the substance use if they continue using in light of that information? I've said to patients who are still ambivalent, are still considering whether they have a problem with substance use, that I indicate to them that we're going to take a test over the next couple of months. So I've told you that any use of alcohol in the next year risks seizures and greater injury and loss than you've already experienced. Under those conditions, using would suggest that having a drink was more important than your health or success. With that information, would you consider that having a drink in the next year would suggest that you have a problem with alcohol? If we're able to engage the individual, and very often at the stage that I see patients, they're often willing to concede that yes, that would suggest that they have a problem. And so that lays the groundwork for them to at least move from that level of pre-contemplation to maybe actually considering whether they have a substance use problem that needs more formal attention. When you've enrolled an individual with an acquired brain injury into a substance use program, we need to be thinking about what kinds of accommodations can be made so that the individual can be more successful. So it's not a question of can the individual adapt to the demands of the program, but more can the program adapt to the abilities of the individual that they're serving. You may need to consider removing access barriers. Are there ramps for individuals who may have compromised mobility? Are there elevators instead of stairs? Do they have a means for getting to treatment? Are they clients of the RIDE, and is that a service that's available? Are there other community agencies that might be able to assist with transportation and getting people to and from treatment? Consider smaller groups. The individual may be able to function reasonably well with 2 or 3 other clients, but 5 or 6 may be more than they're able to be able to manage. The information that you're presenting to individuals in a given session, can that be broken down? Maybe for these individuals, they are anticipating a longer treatment time so that you can cover the information at a slower pace and allow for better acquisition. Is there enough time in the day to allow the individuals to take their time and to be able to process the information before moving on to the next piece? So in the rehabilitation setting, individuals who have memory difficulties, we talk with them about the multiple compensatory prosthetic environment tools that are available for people out there. It may be something as old-fashioned as a memory book or a daily diary, scheduling an appointment journal where people keep track of their day, where they can write down information. We want to try to encourage rather simple and easily managed strategies so that individuals get into the habit of writing down important information in the same place so they can remember where they recorded it later on when they need it. Increasingly, technology is a friend of our clients with the iPads, laptops, tablets, smartphones. These can be incredibly useful for individuals as they learn how to dictate, and with voice recognition software, they can generate notes and reminders to themselves. They can set up in their calendars prompts and reminders for things like homework practice, taking their medication, showing up for appointments, when they're supposed to meet individuals. Making sure that homework assignments are written down, taking a few moments after a homework assignment has been given to meet with individuals on their own, to review the assignment, to make sure that the individual understands what the assignment is, to maybe even run through a little bit of problem solving and troubleshooting to see if there might be some barriers or things that might get in the way of completing the assignment, and doing some problem solving and brainstorming about how to overcome or get around some of those barriers. You may need to modify material to make it more concise and to the point. Individuals may do better with less information than longer explanations for material. Thinking about when you give out material that you visually highlight the essentials, the key elements, that you've taken the highlighter and emphasized the key points that you want people to remember. If there are key concepts that you want individuals to retain and remember, making sure that there are repeated opportunities to hear that, so that there's overlap, there's repetition, there's redundancy in the work that they're being able to do. Thinking about using multiple formats, obviously verbal, lecture, didactic conversations, but also have visual verbal, having handouts, having PowerPoint slides so that people can see the information as well as hear it. Having visual displays, photographs, diagrams that help individuals who may have language difficulties understand the information. And ideally, using multiple formats so that you're hitting more than one modality to maximize an individual's understanding of the information. Where possible, do not just assume that the lack of questions and an attentive look means that the individual is actually following what you're saying. Taking the time to ask the individual to repeat back to you the key points of what's been said, to try to summarize what the main points of what's been going on, to check that they really understand the information. This also is a useful tool in helping them to retain the information, because if they've had to organize and summarize the information, they've worked with it, then that tends to create stronger memory traces for the individual later on. Our folks do better when there are routines and they're developing habits. So thinking about how to set things up so that they're doing things the same way each time. Running classes so that they start and end in very similar fashion, so that the individual is able to come in and more easily and more quickly orient to the activity and to the focus of the group. You may need to provide more frequent rest breaks for individuals. Breaks may be simply a matter in the course of a group activity, just taking a few moments for people to sit back and take a deep breath. In other cases, you may need to consider for individuals that they don't have back-to-back activities, that they have time in the day where they can sit and really de-stress and to reduce stimulation, maybe with sound-canceling headphones. Dark glasses really reduce the sensory input around them to allow their brains to quiet down and to recover. They may need more alternating activities. They may not be able to sit and listen and take in, do a lot of cognitive work for extended periods of time. They may benefit from alternating that with some physical activity, with getting up, moving around, doing some stretching, some yoga, those kinds of things. May need to be mindful of pacing to avoid overload or fatigue, that too much information the individual just reaches a point where they can't take it in anymore, and they just lose whatever comes along afterwards. This, of course, can lead to disruptive behavior. It can lead to people getting frustrated and confused and being disruptive within the group or dropping out of treatment altogether. Thinking about the environment in which you're operating. Our folks often have a difficult time being in stimulating environments, grocery stores, with the overhead music and the variety of displays, all of the visual input, people moving around, moving through space. It can be very, very challenging and uncomfortable situations or environments for our folks. But even in treatment environments, how quiet are the rooms? Is there interference from the hallway noise, from phones ringing? Encouraging people to turn off their cell phones during times when you want them to be able to pay attention. Are there other people talking in the room? Is the TV on in the background? Is there music playing? Our individuals, our clients often can do one thing at a time well, and the more demands that are being placed on the brain's attentional abilities, the more difficulty they get into. It also can be the kind of thing that drains their cognitive battery, if you will, and so contributes to and accelerates fatigue if there's too much going on. They may be able to concentrate for periods of time on what you're saying, but at enormous cost, and they can't sustain that. There are other things, dark glasses, which can cut down on the amount of light and visual stimulation. Different lighting, softer lighting. The overhead fluorescent lights can be very difficult for a lot of our folks to tolerate and very fatiguing over time. Sound canceling headphones, earplugs, earbuds can be very helpful. Just to be able to cut down on the ambient noise around individuals. Again, particularly during rest breaks, it's important that individuals really rest and they have an opportunity to really cut down on demands on the brain and input into the brain. Thinking about having a quiet room or a quiet corner that an individual is able to access freely as they need to. One of the difficulties for our folks is that they're not always able to anticipate and gauge when they're going to run out of gas, and that can happen very abruptly and very quickly for some individuals. They are also often able to recuperate if they can go to a quiet place where there may be a mat, they can meditate or just sit quietly, or they take a short nap, and that can be enough for many individuals to be able to come back and re-engage in the activities around them. Providing assistance with homework or worksheets, helping an individual make their way through. It may be a matter that they have a coach or they have an aide who can walk them through, maybe read the questions to them and have them respond orally to the questions, and then the aide records the answer for them or helps to dictate the answer to the individual while they write it down and record it on their own. There are training strategies that we use in the Rehabilitation Center that are useful to consider and think about when you are training new skills for our folks. Thinking in terms of stages of training and acquisition, the first being the acquisition of the skill. And so this is often in a highly specialized or structured environment, maybe in a classroom or an office, very little stimulation, very little else going on. It may be very structured in the sense that the therapist may walk the individual step by step through the new skill and providing them with adequate opportunity to repeat, rehearse, and to really acquire. Once the skill has been acquired in that artificial environment, that skill then needs to be applied to more real-world kinds of environments. We think about the context in which the skill is going to need to be used. So thinking in terms of the level of stimulation or the environmental noise, if you will, that will be similar to the environment that the behavior is going to be applied in. So you may think about some anger management training or frustration management or relaxation training that you train an individual for in your individual office when there's no one else around, no other distractions, and they can follow you step by step through the instructions. You get them to a point where they can respond to simple initiation prompts, and then you bring them out into the larger treatment milieu, and you expose them to more stimulating kinds of environment, and then prompt them and walk them through the use of the application of those relaxation strategies in more real-world environments. And then thinking about how to adapt those skills that you've trained to the real world, to the environment in which the individual is actually going to have to be able to apply them. So that may be into the home environment or the work environment or the larger community environment. At that point, thinking again, as we have been saying all the way through, involving family members, caregivers, if the individual is in a rehabilitation or a group home kind of environment, that you pull in the workers who are going to be seeing them in the real world environment and involve them in this acquisition and application process. We think about external versus internal skills and abilities. We start out where the prompting and the reminders for the use of various strategies are external. That may be staff or family members reminding the individual to engage in the identified or the trained skill. Over time, that may be able to be transitioned over to electronic devices so that an individual gets a prompt to engage in practice episodes, or before going into key environments or potentially triggering environments, they're reminded to think about or call up these skills to be able to utilize them. Over time, ideally, these external cues and prompts become internalized so that the individual learns to be able to remind themselves or prompt themselves to initiate these skills and abilities as they need to. Now, obviously, not everybody is able to make it that transition from external to internal. The extent to which the external strategies and prompts are needed may be a determiner in terms of how independent the individual is going to be able to be in the environment, and may have implications for discharge planning and return to the community. There's a strategy known as errorless learning. The alternative is trial and error, where you present an individual with a problem and you encourage them to solve the problem. And they try different things out, they see what works, they alter their approach, and over time they figure out the solution. The problem with that for many of our brain-injured individuals is that they are picking up a lot of misinformation along the way, and they're having trouble really learning from their errors. And so they may not be able to arrive at a very effective strategy in the end. The alternative is to identify what the correct solution is and to walk the individual step by step through that solution, stopping them if they make a mistake, starting over again, giving them feedback immediately upon either completing a step successfully or not, and again, going back and having them do it again until they get it right. Once individuals have acquired new skills, they're going to need more time in order to really solidify these memories. So there's the notion of spaced retrieval. So an example might be where we are training an individual in basic orientation, and we're having them hold on to what is today's date, what is our location, why are you here? So initially, I would present that information and I would ask them immediately, so what did we say the date was? We'd said that it's May 24th. That's correct. What was the date? It's May 24th. That's very good. Now, one more time, what's the date today? It's May 24th. So we're doing repeated retrievals immediately upon presentation of the information. Spaced retrieval would be making sure that they have the orientation information. And then I say, now in 5 minutes, I'm going to ask you that information again. So I want you to hold on to it. And so 5 minutes goes by and I stop and I say, now what is today's date? And over time, we increase those intervals in order to really secure and solidify that learning. Another strategy that's commonly used in the brain injury world is the notion of chaining. If you think about many of the activities that we engage in, they're actually a chain of behaviors. It's not a single behavior. An example that we use frequently in talking with people about this concept is brushing your teeth in the morning. So brushing your teeth actually involves a string of behaviors to be completed in order to have brushed your teeth. You have to take out the toothbrush. You have to take out the toothpaste. You have to put the toothpaste on the toothbrush. You maybe run the toothbrush under the water a little bit. You have to bring the toothbrush up to your mouth. You have to put sufficient pressure on the toothbrush against your teeth and move the toothbrush up and down and back and forth, fronts and backs, insides and outsides. You then have to rinse the toothpaste and spit it out. Then you wash off the toothbrush and put it back in the holder. So chaining would involve starting the individual out where you have them at the very beginning. So we're going to brush your teeth, and we focus on getting them so that when they hear that, they pick up the toothbrush and they pick up the toothpaste. And then you tell them, okay, that's very good. Now I want you to put the toothpaste on the toothbrush. And they do that. And then you walk them through each of the subsequent steps, prompting them to do each of the next steps. As they acquire the first step, you then move to more independence with the second step. And once they're able to do the second step, then you prompt simply, we're going to brush our teeth. They do step 1, step 2. Very good. Now you take them through the rest of the steps, providing the prompting. And you gradually are fading your involvement, your prompting and cueing as the individual acquires each of the sequences in this chain of behavior with that. When we talked earlier, when I spoke about external versus internal supports and strategies, prompting and cueing is a form of that, is an external form of support. So it may be visual cues. So you have stickies up on the wall, or you have a schedule posted reminding the individual of what their day is going to be. You have reminders. I have clients who will write down the things that they need to remember on 3x5 cards, and they have them posted on the mirror as they're brushing their teeth to remind themselves of these different strategies. They may be things like compensatory strategies or coping strategies that we've been working on, self-affirmation kinds of strategies. Audible cueing may be in the form of an auditory prompt on your smartphone, an alarm that goes off. It may be listening to brief recordings reminding you at different times of the day of coping strategies and things that you're supposed to be doing. Tactile prompting may be hand over hand. So in the example of brushing your teeth, where you actually take the individual's hand and you bring the hand up to their mouth and you initiate the proper hand-to-mouth movement and teeth brushing. The environment itself can begin to be a prompt where, a good example of an environmental prompt that we all follow is that we generally tend to behave differently at church than we do at the football stadium. There are elements in the environment that prompt us towards appropriate behavior. Those may need to be things that are made more overt for some of our clients in reminding them of what's appropriate or what's not appropriate or when to engage in certain kinds of behavior. Again, the extent to which the individual is able to internalize these prompts and cues will go a long ways towards determining how independent this individual will be able to be in the environment. Again, technology has been a big boon to be able to take a lot of these previously external cues that are people dependent. You needed a parent or a spouse or a partner or a friend, caregiver to be able to provide these. Then increasingly, electronic devices can be set up to provide a lot of these prompts and reminders for people on their own, so that they do not need to have other people around them to be able to be successful. Part of the accommodation, we've been talking about learning styles and the ways in which individuals are able to take in information and process information. We also want to consider allowances and tolerance for behavior that might be disruptive and in other circumstances might lead to the expulsion of individuals from the program. The idea of being resistant and non-compliant and not following through can be a significant problem in treatment. Excuse me. When faced with issues of non-compliance, I think it's helpful to consider what are the causes for the resistance. Is this a choice that the individual is making? They just don't want to do it, or they disagree with it? Or could it be more related to some of their cognitive issues, that they don't understand the expectation? They don't understand the behavior or the information that they've been given. They're not able to distinguish when to engage in the behavior. They're not reading the cues in the environment. They're not remembering the instructions from the day before, so therefore they're not engaging in the behavior in that way. Is the environment too stimulating? Is it too distracting for them to be able to remember, or again, recognize when they're supposed to be engaging in certain behaviors? Are they feeling overstimulated or disconnected from the environment around them? They're not able to keep up. They're not able to relate. So they're withdrawing and disengaging in that respect. We typically find that disruptive behavior is most effectively addressed through a team approach and through a collective understanding. So when we're faced with disruptive behaviors in the rehabilitation environment, we try to take a step back and we try to gather information and gather data. We try to define what the target behavior is. Moving from generic terms like agitation or disruption to being more specific. They yell, or they're making a lot of noise, they're inattentive, they're interrupting. What exactly is the behavior that you're seeing? Can you get to the point where 2 or 3 people can describe the identified behavior in similar enough ways that they're literally on the same page with what the problem is? Then we try to collect data on the behavior. We try to get a sense of when is this behavior most likely to occur. We try to think about try to identify when is it less likely to occur. Can we identify factors in the environment that might help to predict when this behavior might happen? Can we look at what happens after the behavior in the environment, which might in fact be reinforcing this behavior for the individual? When we've gathered this information, we've assessed the behavior, we've done a functional analysis like this, we then look to see, is this a matter of we need to alter the environment to make it more supportive and adaptive for the individual? Are there skills or abilities that the individual needs to acquire to allow them to be more successful? Do we need to alter the contingencies in the environment, both in terms of prompting and helping the individual recognize when they're supposed to engage in certain behaviors or refrain from certain behaviors, as well as how the environment reacts to the behavior? Is the individual escaping certain situational demands by engaging in this behavior? Are they getting a lot of attention when they engage in this behavior? Are they getting a rise or reaction from other people when they engage in this behavior? Can we change what happens afterwards to reduce the reinforcement for these behaviors? At the same time, it's very helpful to consider the alternative behavior. What do you want them to see? What do you want to see them doing instead? Instead of calling out in the middle of a group activity, we would like to see them raise their hand and wait until they've been acknowledged. So at the same time that you may be ignoring the called out response for the individual. You want to make sure that when they do raise their hand, that you're catching that, you're reinforcing that. Good job, David, raising your hand and waiting. Thank you. It helps us a great deal when you do that. Now, what would you like to say with that? Again, in considering the accommodations for behavior, you've worked with an individual in your office. They've demonstrated to you that they're capable of engaging in certain targeted behaviors. But then when it comes time in the real world to actually utilize these behaviors, they don't show up. Is the individual being resistant? Are they being difficult? What's going on here? Well, it simply may be a matter of that this is what happens in acquired brain injury, that skills and abilities learned in one environment do not automatically translate to other environments. Much behavior that we engage in is dependent on prompts and cues that we receive from the environment, questions that other people might be asking us, body language from people around us that give us feedback in terms of when we're supposed to engage in certain behaviors or refrain from others. And our folks with acquired brain injuries may not recognize that, may not pick up on those as easily. So they may not be receiving the prompts they need, that now is the time to engage in that trained behavior. And so we may need to think about how can we prompt that behavior more deliberately or more overtly. Individuals may need more time to actually role play. It's one thing to hear about a skill or ability, but they may need to actually try it out. And so thinking about different scenarios. So I know, David, that you get upset when talking with your mother. So we've talked about some things that you can try when she talks to you. Let's see if we can't do that. I'm going to pretend to be your mother and you be you, and let's have a conversation. And you try it out. In vivo rehearsal. So you're thinking about group activity or behavior in the group. You practice that, or you rehearse it, you acquire it in your individual office space, and then you bring the individual back to the group. But beforehand, you let them know that here's what we're going to do. Now is the time that we're going to actually apply these skills and behaviors. And maybe you review it with them ahead of time beforehand. And maybe you begin to prompt them in the real world situation. And as they acquire, as they demonstrate that they're able to follow cues and prompts in the environment, see if you can't, the extent to which you can fade those cues and those reminders. There was an interesting study done by Corrigan and Wagner back in 2007 looking at retention strategies for individuals with brain injury and substance use disorder. And they actually provided a financial incentive for program completion. And not surprisingly, they saw a much higher rate of completion for those individuals who were incentivized. Excuse me. As we've been saying all the way through, taking a look at and thinking about family and caregiver education and involvement, the more that an individual has an opportunity to practice and rehearse behaviors, the more likely it is they're going to be able to acquire and retain that behavior, and the better job they're going to be able to do in order to, in terms of actually applying that skill and information in real world settings. So if you're finding that certain prompts and certain approaches are effective in the treatment setting, can you involve family and caregivers and teach them some of the same strategies so that this success can translate into the home environment and into the larger community? I think it's important to, while you may understand and appreciate that a behavior that you're seeing that may be disruptive as a result of the brain injury, that's an explanation, but it's not an excuse. And I think people need to have very concrete feedback. Again, it's not unusual that individuals with acquired brain injury may not read a room very well. They may not read body language very well. They may lack an appreciation for subtlety. And so you may need to be very concrete and deliberate that, when you speak to people in that way, it causes offense. Those words that you're using are upsetting for many people. Please do not speak that way, or let's talk about some different words that you can use for that, so that you are helping the individual to identify what the problem is, but you're also helping them by generating and identifying more appropriate alternatives. And again, going back to the strategies that we've just been talking about, giving an individual an opportunity to practice, rehearse before needing to apply those in the real world setting. If an individual is in a group, these folks can be somewhat disruptive in the sense that they may monopolize the conversation, or they may be somewhat tangential. The connections they think they're making with the larger group discussion may in fact not be very connected. And so in a respectful way, being able to give individuals feedback as to when it's time for someone else's turn, maybe talking with them afterwards about what happened, giving them that individual feedback in a private manner rather than in the middle of an entire group. Remind the individual of what the primary topic is and that we're going to get back to that and give some other people a chance to participate. If you've been working with an individual over time, it may be possible to develop some cues or signals for the individual that they can recognize when they are engaging in this troublesome behavior, this identified behavior. And with your cueing and prompting, can begin to self-monitor a little bit more effectively and self-regulate a little bit more effectively. Again, when an individual is not being compliant, when they're not showing up on time, when they're not making it to group, don't assume that this is because of a lack of motivation or resistance. There may be elements of the individual's cognitive difficulties, time management, mobility and access, being able to get themselves organized. I had an individual I worked with who had a tremendous amount of difficulty getting out of the house on time, because he had memory difficulties, and he would have a backpack that he needed for the day, and all of the stuff that he needed for the day needed to be in the backpack. And if the backpack was packed properly, he could have a successful day. But if he was missing items, that could really throw his whole day off. So he would spend time, he would pack his backpack up, he would go and have breakfast, and then he didn't remember what he had put in the backpack, so he would have to unpack the backpack, check everything, and then pack it back up again. And then he'd go to brush his teeth, but he couldn't remember that he packed everything up in his backpack. So he'd have to unpack the backpack, put everything back in. Then he'd go and get his jacket in order to go out, but he couldn't remember if he packed everything in his backpack. So he'd have to unpack the backpack, and so you can imagine it would take him forever to get out of the house. So we developed a system where we had a checklist for the things that he wanted to have in his backpack. And we laminated it, and we used a dry erase marker. And in the morning, when he would pack his backpack, he would check off each of the items. And then once he had the list completed, before he would unpack the backpack, he would check his list. And this allowed him to get out of the house on time and begin to make his appointments. So doing a little bit of detective work, trying to get a sense of why is this individual not engaging in the behavior? Again, do they understand what's being asked of them? Do they recognize when they're supposed to engage in this behavior? Do they have the cognitive and attentional load to be able to manage these behaviors in a real world setting? Again, emotional disruption, emotional regulation can be a challenge, and it requires the individuals around to be monitoring the individual. Again, their ability to self-monitor may be compromised. At the same time that they're paying attention to the external environment, they may not be able to pay attention to the internal environment at the same time. So watch for indications of frustration or for overload. Individuals who are shutting down, they're getting tense, they're starting to exhibit agitated behavior, foot tapping or hand wringing or other signaling behavior indicating that they're starting to get frustrated and starting to get worked up. When you begin to see those signals, that you prompt them and you ask them, do you need a break? David, you look like you're getting a little bit overloaded. Do we need to slow down? Do you need to take a deep breath? Do you need to take a walk or go get a drink? I think it's important when individuals are emotionally activated that those around them be very mindful of their own behavior and that you remain calm and you model the desired behavior, that you lower your voice, you slow your cadence, you speak in softer terms with the individual. So you are demonstrating to them how you want them to behave. Give suggestions or choices for maintaining or regaining control. We can take a walk. We can leave the room. We can sit over here. We can say and do nothing for a few minutes. These are various options. But continuing to yell and scream, this is not something that we can keep doing. So I'm going to ask you, take a walk with me or come over here and sit down. Take a deep breath. Let's take a few minutes and pull yourself together before we proceed. Going back to the behavior analysis that we were talking about previously, as you begin to get an understanding or begin to see a pattern in the behavior, being respectful of an individual's limitations and trying to avoid triggering situations. If you've been observing that the individual has a difficult time in large groups, try to avoid putting them into large groups. If you notice that when they get tired towards the end of the day, that they have a harder time with more emotionally laden material. Think about the schedule and avoid having them in those sort of more emotionally laden or potentially triggering activities later in the day. Maybe they do something that's more calming and soothing and relaxing later in the day. And the more potentially activating activities are done earlier in the day when they have more reserve and more ability. Allow for and encourage rest breaks. And for individuals, particularly in this day of constant media exposure, really talking about shutting down for short periods of time, turning the phone off, getting off the screen, closing up the iPad, having some quiet music that they can listen to or very low stimulating. Again, thinking in your clinical environment of having break rooms where individuals can sit in a slightly darkened environment where there's not a lot of noise and they can just rest and compose themselves. Being able to take a short nap during the course of the day. These can be really restorative activities that allow individuals to get back on track. Discourage people from trying to power through or tough it out when they're experiencing fatigue. This can often, for many folks with acquired brain injuries, actually continue the loss of energy, can result in headaches as a form of brain fatigue, which is not going to benefit them at all. When we were talking about executive functioning or executive dysfunction, the ability to anticipate and appreciate the consequences of one's decisions and actions may be compromised. And so you may need to walk people through and stop. And David, let's consider, if you were to do that, if you were to say that to these people, how do you think they might react? If the individual is able, David is able to identify, said, that's right. Is that the kind of response that you want from people? How would that feel to you if you're in that situation? You may need to be more concrete and say, David, if you say those kinds of things, this is how people react to that. This is how people interpret that. Is that what you're looking for? Is that the consequence that you're looking for? Let's talk about some other alternatives, some other things you could try in order to have a more successful outcome. At the same time that, as we spoke before, that you're trying to eliminate problematic behavior, you want to try to be thinking about alternatives that you can reinforce. People respond much better to praise than they do to critical feedback. They respond better, their self-esteem is improved when they're told that they've done a good job on something rather than that they did not do a good job on things. It's very valuable to consider that when you are trying to prompt and train new behavior, that as much as you can reinforce each time that behavior occurs. the stronger that behavior is going to be. Over time, you can fade that prompting, but in the initial acquisition stages, prompting and reinforcing that behavior each time it occurs is really valuable. And again, using role play to practice responding to emotional triggers, more structured, better paced environments, so that again, an individual may, in the abstract, acquire a skill in your office space, but giving them a chance to actually walk it through, to use the words, to translate some of the responses in their own into their own words, so that they have a chance to practice it, so they have some real confidence in their ability. Again, the challenge in the project that we've engaged in is that these trainings are not going to make you experts in brain injury. And there are individuals who've devoted their career towards this topic of accommodation and helping people to be successful. And so when you are identifying an individual whose brain injury is posing a barrier to participation in the treatment, reach out to the resources that we've been identifying and have been providing you over the course of these trainings. The Brain Injury Association of Massachusetts is an excellent resource. The Statewide Head Injury Program is another exceptional resource for individuals. Making sure that your clients are members of these organizations. If an individual has been injured significantly enough to end up in a program like ours here at Spaulding, we try to make sure that they're all enrolled in these programs before they discharge. But the majority of individuals who sustain an acquired brain injury may not ever make it into a hospital setting, and so may not be aware of these organizations and these resources. And again, contact information for each of these groups. So I wanted to take just a few minutes. We've got some time to be able to think in more concrete terms about some real life scenarios, and thinking about your organization, and if you had this client in your organization, how your team might be able to approach some of these challenges. So the client we have in question is a young woman by the name of Stephanie. She's a 22-year-old college student. She was injured in the past year in a motor vehicle accident while driving under the influence. She started back in high school with drinking and also uses marijuana on a regular basis, and occasionally ecstasy as her drugs of choice. She's in treatment because of court order following the loss of her driver's license, and so her motivation for participation in the treatment is primarily to get her driver's license back. From a brain injury perspective, she has problems with attention, concentration, memory, problem solving. She's been demonstrating that she has low frustration tolerance. She gets into arguments with people. When she does, she yells, she curses, she storms out of the room. She can be very dramatic and disruptive. Fortunately, there's been no physical aggression. It's been limited to just verbal altercations and verbal disruption. She has a girlfriend of several years. She's been living with her parents after living on her own. She previously, before the accident and the injury, enjoyed outdoor activities like camping and hiking. So I'd like you to consider, what problems might you expect Stephanie to have in participating in your treatment program? And I'm wondering if Justine, we can have individuals enter their thoughts or suggestions into the chat room, and perhaps you can either share that with me or read that to the group.
Absolutely, Dr. Carter. When we have some responses here, I will relay them to you from the chat. So feel free to put those responses in the chat. Thank you.
So Stephanie arrives to your individual therapy session as scheduled at 1 o'clock. She's already been to an exercise group and group therapy. She's having difficulty focusing during the session and even closes her eyes at times. And what could be the reasons for this? What solutions might improve her ability to participate in sessions? We might consider that at this point in the day that she is really probably cognitively overwhelmed and fatigued, that she's really feeling kind of burnt out. She might benefit from a rest break between therapies to allow for improved cognitive endurance. So does she need to do the exercise group and group therapy, or might she be just as well served by one or the other in the morning? Can they be scheduled at a time that allows her for a break in between times? Could your session be planned a little bit later in the afternoon so that she can have some time to reconstitute after she eats and to compose herself? It
Dr.
might.
Carter, a
Yep.
couple items coming in.
Good.
Mimicking and bearing what you're saying, move the time. This person could be overloaded. Too many activities in one day. Someone suggests switch the days. Change work out time, maybe go to a later exercise class. The lighting in the room might need to be adjusted. Someone says Stephanie's motivation may be in the wrong place, overwhelming schedule. Again, similarly, too many activities, too rigid of a schedule.
Excellent. So thinking about Stephanie's ability to be flexible and adapt may be limited. Can we step back and be more flexible in our approach? Does everything have to be exactly as we've scheduled it, or can we will we be more effective with Stephanie by allowing her some alternatives within that? I mean, even thinking in terms of allowing her to wear dark glasses if there's a lot of fluorescent lighting, even just a baseball cap, although with her hairstyle that might be problematic, but just the bill of the baseball cap can provide sufficient cover to help cut down on some of the glare there. Exercise is generally recommended for anybody with any sort of emotional difficulties, and we know that that's a key component to substance use recovery. But we have to consider that for individuals with brain injury, there's really one battery that feeds both systems, both the physical and the cognitive. So that an individual who's engaged in a lot of cognitive activity may feel very physically tired. And conversely, if they've been very physically active, if they've had to do a lot of walking, and how much movement is required between the different activities, that all that physical activity doesn't leave much left over for the brain in order to function. So all good suggestions and thoughts.
There's a couple more. Would you like me to continue?
Yes.
Reading the couple more that came through, Dr. Carter?
I think so. We have plenty. We're doing okay on time. Yeah.
Okay. So someone suggests, I wonder if there's a brain injury due to the drug use. Then what is the situation that contributed to the self-medicating?
So this is the interesting interface between these two realms. So going back to the original presentation for Stephanie, I would certainly want to have a better understanding of her reason for drug use. Obviously, as a psychologist, I'd be interested in knowing about her family background and history of trauma, that sort of thing. It indicated that she had a girlfriend for a number of years. How comfortable is she in her sexuality? How comfortable and supportive is her family in her sexuality and in her identity? Have these been causes for her substance use? Was there pre-existing difficulties with depression that was contributing to the medication, the choice of drugs that she had within that? Now that she's been injured and her life has been disrupted, she's lost her independence and is now back in with her family. Is that creating additional difficulties, frustration, depression, etc.? She is here in treatment because she has lost her license, and she's hoping that upon completion of the program that she'll get her license back. But is she really ready to acknowledge that she has a substance use problem? Does she understand the connection between her substance use and her current cognitive difficulties? the question of injury from substance use, not typically at her age would I be thinking that the alcohol directly or the marijuana use or the ecstasy itself directly. Longer, more prolonged exposure, that would be a concern for that. The more likely culprit with alcohol is the alcohol-induced accident and injury sustained in the accident itself. And so then, moving forward and talking with Stephanie, does she have an appreciation for the risks of continued use of the alcohol and the marijuana in terms of her recovery? Does she identify that she has difficulties with attention, with concentration and memory? And does she appreciate the negative impact of these substances on those things that she's struggling with? Stephanie's been exhibiting difficulties with maintaining conversation in group settings. She's having difficulty focusing on movies and common areas. She's easily distracted and is at risk for choking if she forgets to follow her swallowing strategies while eating. What sorts of accommodations or supports could be offered to help Stephanie with some of these difficulties?
Role playing, someone says.
What role would you think about having her play or rehearse?
Other ones coming in, increased distractions, smaller groups, one-to-one while eating, modified diet, smaller group setting, having her watch TV alone, counting her chews. Stephanie may do well having meals at a quiet table rather than in front of a TV. Noise canceling headphones. See that? Meal times should be with other people. She should have people who can intervene if she aspirates, but in an environment where people agree to be quiet.
Really good suggestions, really thinking creatively. I mean, coming up with generic responses to some of these questions can be tricky. A question would be, how comfortable is Stephanie with these limitations? How much ownership is she able to take? Again, the distinguishing between attentional difficulties, she gets distracted, and memory difficulties where she forgets. And at the same time, it's one thing to know what you're supposed to do, and it's another to remember to do it when you need to, and that can be a problem. Some people will have, again, prompts and reminders on their phone. Some people will have a little 3x5 card. A strategy we use here in the hospital, where there's obviously a little more privacy, is just a folded card with a couple of prompts on eating strategies, swallowing strategies that we put on the tray with the food, so that the individual gets that initial prompt. Pairing her up either with an aide or a support person, so she's not socially ostracized during meals, but someone who is aware and can provide her with the reminders to slow down, and the suggestions that were made, counting her chews and that sort of thing. Instead of watching a movie in a common area, can it be set up on a laptop or an individual computer with her own headphones, so she can tune out the background noise, or even can a transmitter be set up so that she can listen on her own headphones in the common area. And sometimes in a group setting, just suggesting that she just try to listen and not necessarily engage or participate in the conversation, but try to take in as much as she can. It may be a matter of the group facilitator and the group leader may needs to slow things down a little bit and giving Stephanie enough time to perhaps give her a summary. Stephanie, these are the things we've been talking about. I'm wondering how you're thinking about that, or what how you're reacting to what people have been saying, and creating space for her so she doesn't have to break into a conversation or be able to track and follow the content from multiple speakers like that. Stephanie has difficulty remembering her daily schedule. She has difficulty recalling names of staff members, especially new staff. She requires cues to recall her swallowing strategies at all meals. Stephanie has difficulty recalling daily events. I have two questions for people to consider. What kinds of accommodations or alterations could be made at a programmatic level to support her around these issues? And what implications might this have for Stephanie's plans to be able to live independently in the community?
We have using her phone calendar, printed daily schedule, smartphone alerts, name tags on staff, reducing her stress level, or possible cue cards, a visual calendar, timers,
And she may benefit from more frequent checking in on the part of an individual staff member. Stephanie, let's take a look at your schedule. What have you been up to so far today? And making a note of that, encouraging her to carry a journal or a daily planner that allows her to jot down summaries of what took place in the different activities. For group leaders to be thinking about a few minutes at the end to summarize the key points. So Stephanie, these are the main things we talked about today. Let's take a few minutes and get them into your calendar, and either writing that for her or dictating to her or having her summarize and you write and enter the information into the recording device that's there. During the course of the day, connecting in with her and reviewing what's still to come and meetings that she's going to have or that sort of thing. Sort of meeting at the end of the day and just sort of summarizing what's been going on and taking a look if there are assignments or homework that she understands what's taken place during the course of the day. I think in knowing that it's a bit of a fine line in terms of not assuming that Stephanie remembers, but at the same time, not also assuming categorically that she hasn't remembered anything. And so talking with her and working out an acceptable level of prompting and reminding of new information, making sure that new staff, people who are new to Stephanie, reintroduce themselves. I know you're meeting a lot of new people here, Stephanie, so I just want to make sure that you know who I am. This is my name. This is what I do here. This is what we're going to do together. And continuing that approach until she is able to initiate. Hi, Chris. How are you today? And can demonstrate that she knows that information. So lastly, emotionally, behaviorally, Stephanie gets easily frustrated during group and therapy activities. She gets into arguments with others. When she gets upset, she yells, she curses, she storms out of the room. What kinds of things might be causing this behavior? And what accommodations or supports could your program offer to help Stephanie manage her frustration and anger more successfully?
Someone asks, what is her home life like?
That's a good question. What is she bringing with her to the therapy, to the group activities?
We have suggestions of possible anxiety, breathing techniques are suggested. Her lack of understanding of her injury, possibly. Cues to take a time out. Overstimulation may be a factor. Processing all what is going on and being said. She now has to understand her new limitations. Smaller groups may be more helpful.
So I like that you're incorporating the notion that many individuals with substance use disorder have to go through a process where they take ownership of that disorder, and they have to incorporate that. Individuals with acquired brain injury have to go through a similar process of acknowledging and accommodating these injuries and these limitations, and that can be a very emotionally difficult process for people to go through. So, wondering about her adjustment to her injury and to her situation. If she's overloaded and having trouble keeping up, the frustration of that, not being able to feel a part of things and feeling separate from the rest of the group. Good question in terms of what is she going through in order to get to the group, and maybe she needs some time first thing to just get grounded and calm herself. A lot of the strategies that are used in dialectic behavior therapy can be very effective with individuals with brain injury in terms of pulling themselves together, getting in touch with their emotional state, paying attention to what's going on with their body, recognizing when they're getting frustrated and upset, and then again providing them with cues and prompts and opportunities to practice and rehearse within that.
Couple other quick suggestions here before we move on, Dr. Carter, just so that we sort of incorporate these last suggestions, because it's been wonderfully great participation here. Someone suggests food and mood is real. What is she eating before therapy? Does she view people in the group as her peers? Are they similar in age? And then lastly here, we have we determined Stephanie even has had an accident resulting in TBI? She may also have underlying mental health diagnosis, and one-to-one will help her talk about her life now and allow her to miss her past life.
That's a good point, that individuals with acquired brain injury are often going through a grieving process, that they are grieving the life that they had, that they've lost. They're grieving the life they thought they were going to have and are fearing that they're no longer going to be able to access and having to deal with the uncertainty of what is in fact possible. The idea that in amongst a group of individuals who may be carrying their own substance use issues, not feeling a part of that group, but also not ready to embrace her identity as someone with a brain injury within that. So particularly given her age and all the rest of that, these identity issues may be contributing to some of the difficulties that she's having. So some of those more unique dynamics and features that are related to the acquired brain injury. If the injuries are a result of her decisions to drink and drive, how is she feeling about that she is sort of the cause of her own difficulties within that? And again, how is the family supporting her or responding to all of that? So as we said back before, in thinking about the screens for the brain injury, those are simply screens. They're not diagnoses. They're the beginning of investigations and conversations, because all of these questions that you're asking are especially relevant and need to be appreciated in order to be able to come up with successful accommodations, so that someone like Stephanie doesn't simply drop out and lose the opportunity to be successful. We're nearing the end of our time, so let me just jump to the next piece. It's been my experience as we introduce new ideas and teaching modalities and therapy modalities into an organization, that for individual clinicians to be able to carry out these accommodations, that the organization itself needs to think about accommodations that they need to make. That you may need, if you are identifying that you have a number of individuals with acquired brain injuries, and you really do need to consider that a lot more of your clients have brain injuries than may be appreciated, where the substance use is the primary diagnosis. But the number of them have fallen, gotten in accidents, gotten beat up, have had overdoses, have had hypoxic episodes, have had prolonged exposure to their toxic substances, et cetera, et cetera. It's more likely to be the exception. The individual without cognitive impairments and difficulties is more likely to be the exception. And so taking a look at the intake process, what's the informational load on the individual? How much responsibility is the individual required to take in order to make it through the process? How groups are scheduled and activities are scheduled? How tight is the day? Staffing levels to allow for individual contact and supports, as we've been talking about. What kind of adaptive equipment or accommodating equipment may be needed? Changes in the physical space, ramps, doors that open independently, quiet rooms. How does the organization respond to no-shows? How do you manage substance use relapse issues for these individuals? What kind of documentation are you encouraging to allow for or support team communication, so that everybody's on the same page and is making similar accommodations and is responding in a similar way to the individual's needs, so that the individual is getting consistent messaging and more effective learning and training? How are families involved in the larger social network? Are there more opportunities for people to be involved in ways that may not be typical in the traditional approach? Being flexible about different learning styles and paces of learning. Does everybody have to go through the program at the same pace? Is there accommodations for longer treatment exposures? How are the insurance companies supporting these individuals, and how flexible and willing are the insurance providers to allow for some of these accommodations? And looking at your referral and consultation relationships, so that you have a stable of consultants that you can call in, speech therapists and occupational therapists, neuropsychologists who have knowledge in this area and can consult and advise on individual cases. So it's an exciting project, and I've been very pleased and very excited to be a part of it and be part of these trainings.